Hello and welcome to the important topic in the pharmacokinetic, that is plasma protein binding. Now this topic is having its excellent value in theory as well as practical. Many of the short notes, many of the questions are frequently asked in association with the topic. So uh, as far as if teacher is concerned, if some teacher wants to set a paper from the pharmacokinetic, this would be the most preferable questions for them. So it's most important questions from the pharmacology chapter. Both that can be asked in uh, longer questions, or a few short questions can be asked. They can also be asked few of the viva questions from this topic as well. So it's very important you understand the basic concepts related to it. It's very easy comparatively if you go through it thoroughly. Now we have already discussed about plasma protein binding in our previous session. That was what is distribution, right? And at that time we discussed in brief that drugs having different plasma protein binding affinities. Drugs which are having more plasma protein binding affinity are more confined to vascular compartment, and it goes lesser to the periphery. And drugs which are having less plasma protein binding, they are more less confined to the vascular area, and they goes into the peripheral tissues which are having different affinity to the tissues, so their distribution is more. So here in this case there is high distribution is more, and here there is less distribution, so that we know. So let's talk about different kinds of plasma proteins. Now there are mainly two plasma proteins being divided depending upon the pH of drug. So major plasma protein is albumin, and next one is alpha 1 acid glycoprotein. So these are two uh, important plasma protein. There are many there, but these are two important plasma protein out there. One is albumin and second is alpha 1 acid glycoprotein. Now acidic drugs binds with albumin. So A for A becomes easy. If the drug is acidic, it will bind to mostly albumins. And if drug is basic, it binds to alpha 1 acid glycoprotein. Don't think this name contains acid, so it will bound to the acidic drugs. It's a vice versa. Okay, so acidic drugs bind to albumins, and basic drugs binds to alpha 1 glycoproteins. So you need to understand the characteristic of drug, whether this drug is acidic or whether drug is basic. So what if we increase the dose of these drugs? If we increase the dose of these drugs, eventually what will happen if the drug is having a plasma protein binding characteristic, it will try and bind to all the proteins. But still if we increase the dose, all the binding sites will get saturated, and now the free concentration of drug will increase, and it will lead to toxicities. So that is why we need to understand, it's very important clinical point of view also, the characteristic of a drug to bind to the plasma proteins. Now what is the clinical significance? As we have already discussed, high plasma protein bound drugs more restricted to vascular compartment, and there is low volume of distributions. So here in this table, we can learn, or we can remember few of the drugs which are having acidic in nature, with drugs we are having basic in nature and binds to respective plasma protein. So drugs which bind to albumin and which are acidic are mostly, you can remember, these are NSAIDs. NSAIDs are group of drugs that are painkiller group of drugs, mostly all acidic drugs. Anti-epileptic group of drugs, that is phenytoin, benzodiazepines and barbiturates. All these three are anti-epileptic drugs. We'll discuss in particular section. Antibiotics like sulfonamides, penicillin, these are also acidic drugs. Even valproic acid is also anti-epileptic drugs. And drugs like warfarin, that is being used as an anticoagulant, tolbutamide used in diabetes, and tetracycline antibiotics. So few of the drugs you can remember. And what about basic drugs which binds to alpha 1 glycoprotein? That is beta blockers. It's easier. Beta blockers basic. Local anesthetic agents, bupivacaine, lignocaine, these are basic in nature. Calcium channel blockers, verapamil, alpha blockers, prazosin. So you see alpha blockers, beta blockers, calcium channel blockers. So all blockers are mostly basic. So alpha blockers, that is prazosin, beta blockers as we have discussed, calcium channel blocker is verapamil, local anesthetic agent. So this is how you can remember groups which are basic in nature. So you can remember few of the drugs and that can be helpful in Viva. So we are into the clinical significance portion of this plasma protein. Why this plasma protein having its value? You see here in this figure what it's been shown that drug is available in the blood in two forms. One, a free form, and one is bound form. Bound to which? Bound to what? Bound to plasma protein. So this blue structure is plasma protein and this red is a drug. So drug is here, it's not bound, it's a free drug, and here it's been bound to plasma protein, it's a bound form of drug. Now always there is an equilibrium between these two. So always it's in the balance. Okay. So first thing, that free drugs and bound drugs are in equilibrium state. Now, when drugs gets metabolized and eventually gets excreted, will it be the bound drug or the free drug who gets metabolized and excreted? Obviously, it will be a free drug. So, free drug undergoes metabolism and excretion process. And once that portion of drug goes into the metabolism and excretion, a bound portion will try and replace that. So there would always be equilibrium maintained. So you can say this plasma protein acts as a reservoir. So two or three important things we discuss. First, bound drug and free drug are in equilibrium. Second, this free portion or the free drugs only undergoes metabolism and excretion. Third, this plasma protein acts as a reservoir. So bound fraction is not available for action. Yes. Bound fraction acts as a reservoir. Yes. And third important thing, higher the plasma protein binding, longer the action of a drug. If the drug's having high plasma protein binding, it gradually gets released, gradually gets metabolized and excrete. So the duration of action increases. So longer it would be the duration of action. So this is important clinical inferences of this topic. So if I want to say plasma concentration of drug, so it would be bound drug as well as free drug. So bound and free both contributes to the total plasma concentration of drug, and other points we already discussed. One more important and the most important topic that can be asked from this plasma protein are displacement reactions. Now, as the word suggests, displacement reactions means one drug displaces the other. So here you can say this is our plasma protein and this is our drug A and this is our drug B. Now, what is important thing is been written is high affinity. This drug B is having high affinity to what? It having high affinity to this plasma protein. Here both the drugs can bind to the plasma protein. Right now drug A is binding to the plasma protein. What if we introduce drug B simultaneously? So the scenario is normally both the drug binding to the plasma protein, but we have given drug A and now we are adding one more drug, that is drug B. So what happens? Okay, so when you give two drugs simultaneously, drug A plus drug B, what happens? This drug B has higher affinity to bound to the plasma protein. So it will displace this, okay, it will push this drug A from its binding site and releases it. So drug B with higher efficacy binds to plasma protein and pushes this drug A aside. So the concentration of drug A into the blood increases, and eventually what it can lead to? It can lead to its toxic effects. So these are called as displacement reactions. Hope you are clear. Again, I'm saying drug A and drug B is given, two drugs are given simultaneously, then drug with higher affinity tends to bind to the plasma protein and displaces the other drug, and it will increases the free drug concentration and lead to toxic effects. Now, some of the examples, these are the same thing that has been written. Some of the examples are aspirin. Aspirin displaces the sulfonylurea. Sulfonylurea is being used in the treatment of diabetes mellitus. So what happens? The concentration of sulfonylurea increases and it will lead to decrease in the glucose level and hypoglycemia can occur. Indomethacin, phenytoin, this drug displaces the warfarin, so it will increases the toxicity of warfarin and which can lead to bleeding tendencies. Other examples are sulfonamides and vitamin K displaces the bilirubin and increases the concentration of bilirubin, and this bilirubin goes into the brain of neonates and it can leads to condition called as kernicterus, which is very dangerous conditions. So these are some of the examples of displacement reactions and what happens once the free drug concentration increases, that is toxicity. So you can remember few. Now, till now, we have seen in plasma protein the importance of different plasma protein, what is its role, what is its clinical significance, what is displacement reactions. But now we will see two scenarios. So, what if the plasma protein level decreases? So, that is hypoalbuminemia. So, it's a condition where the plasma protein decreases in the blood. So, overall protein decreases in the blood. So, it will lead, so there would be no more plasma protein binding. The free drug concentration increases, and as we have seen earlier, there will increase chance of toxicities. And at the same time, what happens in pregnancy? In pregnancy, plasma protein increases, especially the acid 1 glycoproteins. So it will increases the plasma protein, it will increases the binding of a drug, and it will lead to its clinical conditions. So thank you very much. That was all about plasma protein binding and its clinical role.